Mental health problems obviously affect everyone in the family. If one of the family members develops a problem, everyone in the family is affected by that, whether that's brothers and sisters, parents, children. So obviously it makes sense that if we want to help the person with the mental health problem to recover, we need to help those around them, those who are offering them support and who care for them most. We need to offer them advice, information and guidance on what they can do for the best to help that person. I mean, obviously, lay people, like family members, when it's the first time they encounter a mental health problem, they don't know what to do to help best. If somebody is describing hearing voices or having some odd beliefs or is so depressed they can't get out of bed, it can be really hard for their family to know, what should I do? Should I say that I hear the voices too? Should I tell them don't be silly? Just forget about them? Should I tell them to ignore them? So they need practical guidance and help. So the kind of family approaches that I talk about are generally referred to as psychoeducational family approaches. And what this involves is working with the whole family, including the person who has the mental health problem. And key to this is acknowledging the expertise that the person themselves have around their mental health problem and the expertise the family has about that person and about what works for them. So these are very down-to-earth, practical approaches. They usually involve talking with the family first, finding out what the main issues are for them, and then deciding how to move forward. So one of the things that's often covered is giving the family information about the mental health problem, and helping them to understand it, why it might have arisen, what they can do to help. We also put a lot of emphasis on relapse prevention or on the person staying well. So families are very good at identifying early signs of somebody becoming unwell again. And we try to work with them to recognise these, list them down, agree with them what they will do if they notice these. And of course, another requirement then is that the service responds to the family if the family get in touch because they've noticed these signs. Another thing we do is help the family to communicate more effectively together. So we all know that when we're under stress, our communication isn't at its best. We can get angry more easily, we can have disagreements, we can ask for things in ways that people don't like. So one of the things we do is focus on how people communicate together, helping them to notice positive things when they happen, to listen very carefully to each other, to ask for things in a way that's likely to be effective, or even if it doesn't work, that will keep the atmosphere pleasant, and how to express difficult things to each other, such as frustration or annoyance or anger. So these are very practical approaches, and the family kind of learn new ways of talking with each other. We also help them to develop problem-solving skills, so that if they're faced with difficulties, as they're likely to be because somebody has a problem, we help them to learn a method of solving problems so that they can use that whenever they encounter difficulties, or if it's some goal they want to work on together as a family. Now, the benefits of these approaches have been well documented, and what's clear is there's a really strong evidence base if you use these kinds of family psychoeducational approaches. And the research has been around for over 30 years now, since the early 80s, and clearly demonstrates that if you offer family work in addition to medication for people who have psychosis, schizophrenia, severe depression, you will reduce relapse rates to less than 10% compared to relapse rates of 30 or 40% if the family don't receive help. So very, very clear evidence about the effectiveness of these approaches. And of course, if you reduce relapse and readmission rates to hospital, then you reduce costs of care. So these are approaches that really there shouldn't be an argument about them being introduced into services, because while there might be a short-term requirement for inputting some funds to train staff up or to free up some time to deliver these approaches, in the long run, because of the reductions in relapse and rehospitalisation rates, you actually save a lot of money. But of course, in the services in which we operate, there are often quite traditional models where the focus is predominantly on medication. So it can be a challenge to get people to think about introducing psychological approaches or talking therapies in general. And even within that, people are more likely to introduce talking therapies that are individually based rather than family based, because some staff just don't feel confident in working with the whole group or with the family. So we have to tackle these issues in systems that we can actually support staff in getting over these confidence issues by ensuring that they've got adequate training and that supervision is available for when they start to deliver this work. And of course, managers need to be on board so that this work is prioritised. And in a time when we're in a difficult economic climate, this often doesn't cost more money, because if we think about it, often people are doing things that aren't evidence-based in their work or that aren't effective. And so it may require people looking at their caseloads, looking at how they spend their time already, and thinking what can be dropped so that they can actually do more of this kind of work, which has a very clear evidence base and will produce very effective outcomes. And of course, the other benefit is that we know that if families aren't supported, they're more likely themselves to develop minor mental health problems, anxiety disorders, depression, stress-related problems. So if we can support them, we're less likely that they will develop all around. So what we're talking about really is a situation in which everyone wins. The families feel supported and are less likely to develop problems. The service user has a better outcome and fewer relapses, or less likelihood of relapse. And the professionals feel that they're offering something that's really beneficial, really worthwhile, and can see the outcomes. So it makes total sense for services to begin to incorporate these this way of working, and it's very much in keeping with the vision for change, which you know is being implemented across the country.